Good evening, everyone. Today we are going to start with the MCQ related to general pharma, ANS, blood, and endocrine system. According to the MCQs, which are important according to the exam point of view as well as concept point of view, we are going to discuss that MCQ in that. So for that, I'm going to share my screen with you. Okay. So for general pharma, first we are going to see the questions regarding general pharma. So first question is therapeutic index indicate. So first of all, we have to understand what is therapeutic index. Therapeutic index of a drug is that index which tells about the safety of the drug, how drug is safe for the individual. So in these options, we can see the drug toxicity, drug potency, drug safety, and drugs lethal effects. So our option 3 is correct. Therapeutic index indicates about safety of the drugs. The formula for the therapeutic index is LD50 by ED50. In that, LD is the lethal dose. Lethal dose, it means this is that dose which are required to kill the 50% of the population. Suppose if a drug A is taken by 100 individuals, out of 50 individuals are died because when the concentration of the drug is 50 milligram. So the 50 milligram for drug A is called lethal dose. 50 milligram for drug A is lethal dose because it was able to kill 50% of the population. And ED50 is the effective dose. Effective dose means that same drug A, when it is given to 100 individuals at the dose 50% of the population are feeling all right or feeling effective after taking that drug. So it means ED50 is the effective dose for that 50% of the population. Like for this case, drug A, 50 milligram of drug A was able to have effect in the 50% of the population, and the ratio between the LD50 and the ED50 is called therapeutic index. So therapeutic index tells about the safety of the drug. It does not tell about the toxicity of the drug. It does not tell about the potency of the drug. It does not tell about the lethal effect of the drug. It tells about the safety of the drug. Moving to the next question. Question is least predictable reaction to the drug. Least predictable reaction to the drug. Just a second. So what is the least predictable reaction for the drug? Is that reaction least predictable reaction to a drug? What is side effect of a drug? Side effect of a drug is that predictable reaction which we know going to occur because of the consumption of the drug. For example, if we are taking anticholinergic, it means atropine. If we are taking atropine, we know that after taking that amount of atropine, the body will feel dry. There will be the dryness of mouth, there will be the dryness in the eyes, there will be the dryness in the body. It is a predictable effect which are going to affect after taking the drug. So side effect is the predictable. Toxicity means when we have taken a drug in a higher concentration. If the concentration of any drug A is 10 milligram, and if we have taken this drug to the 100 milligrams, it means we have taken the increased amount of the dose of a drug, then this dose of a drug will have the toxic effect in the body, that is predictable, that if we have taken the drug for a larger period, or we have taken in a larger amount, then it will have its side effects, it will have its toxic effects. So it is the no. Next is the allergy. Allergy means it is the hypersensitivity reaction of the immune system. If someone is allergic to any drug or any salt, suppose if a person is there and he is allergic to the diclofenac, then a smaller amount of the diclofenac will produce the hypersensitivity reaction to that person. It means it is a known or the predictable effect of a drug. So that is, it is not least predictable. It is predictable. If someone is allergic to that drug and we have taken that drug, then it is going to have its effect. So what is idiosyncrasy? We are left with this third option, idiosyncrasy. What is idiosyncrasy? Idiosyncrasy means it is genetically determined. It is genetically determined. It means it is when someone will go for this gene mapping or the genetic testing, then he or she will come to know that some person, that the individual is uh, toxic to that drug, individual is allergic to that drug. So it is the very least predictable, because we have not done our gene mapping or the gene testings, or the genetic testings are not, everyone is not approachable to that testings. So it is the least predictable reaction to the drug. So we are the answer for this question is the idiosyncrasy, which is the least predictable reaction to the drug. Now moving towards the next question. Next question says that plasma concentration of a drug at time 0 is 969 ml. So at time 0, the concentration of the drug is 969 ml. And after one half life, the concentration are going to be reduced. It means if the T half is 2 hours, after 2 hours, the plasma concentration of the drug will be this, half of the concentration. Then after this, and the after 2 hours, it is going to be half of this value. Half of this value will be almost this. Half of this will be after 2 hours, it will be this. Then after 2 hours, the value will be this. And after 2 hours means we have to see the half-lives. After we have seen the 10 hours. 10 hours means after 5 half-lives. After 5 half-life, the concentration of the drug after this will be 30 ml. It means after first concentration, after first half-life, the plasma concentration is reduced to half. Then second half-life, it is going to be reduced to this half. After third, it is going to be this. And after 4 and 5, the concentration will be this. Because after every half-life, the concentration of the drug is going to be half. That is called the T half. So by this, we can calculate any of the drug calculation. In this options, we have seen this 3. It is not 3, it is 30 ml, 30 per ml. So there should be modification in this answer, that it should be 30 per ml. Next question. Next question says that drug showing zero order kinetics of elimination. First, what is zero order kinetics? Every drug follows some kinetics. Either it can be first order kinetics or it can be zero order kinetics. The very important thing to understand what is first order kinetics. First order kinetics means if a constant fraction of a drug is eliminated after every half-life. After a constant fraction of the drug. What does it mean? What is the constant fraction? Suppose if we have given 100 ml of any drug. We have given And we have seen after every time 10% of the drug is eliminated. It means 10 ml of the drug is eliminated. Then we are going to increase the concentration of the drug. We are going to increase, suppose we have increased the concentration to 110 ml. Then 10% of this 110, but 10% is going to be eliminated. It means 11 ml of the drug is eliminated. Then if the concentration is increased to, again we have put 10 ml extra into this, and the concentration of the drug is 120 ml. Then after this 120 ml, 10% is going to be eliminated. It means 12 ml of the drug is eliminated. It means when we are going to increase the concentration of the drug elimination is also getting increased. It means a constant fraction of the drug is getting eliminated every time. Most of the drug is going to follow this first order kinetics. There are some special drugs which follows zero order kinetics. Now what is the zero order kinetics? Zero order kinetics says not a constant fraction of the drug, a constant amount of the drug is eliminated every time. What does it means? It means constant amount. If suppose when there is the concentration of the drug is, we have seen 100 ml of the drug. The 100 ml of the drug is there. This 100 ml of the drug, this 100 ml of the drug is there. A constant amount of the drug is getting eliminated. It means 10 milligram of the drug is getting eliminated. Now we have increased the concentration of the drug. We have increased the concentration to 110. If 110 milligram of the drug is there, then also the 10 milligram of the drug will be eliminated, because there will be the constant amount of the drug is getting eliminated. If we have increased that concentration to 120 ml, still 10 milligram of the drug is getting eliminated. It means when we are going to increase the concentration of the drug, the elimination of the drug will remain constant. The elimination of the drug is not getting increased by the increased concentration of the drug. So what does it mean? There is a drug which getting accumulated in the body. Drug is not getting eliminated that much amount that it is going to be increased in the body. So the amount of the drug is getting accumulated in the body. So this type of the kinetics is called zero order kinetics. There are few drugs which follows this zero order kinetics, like alcohol. For these drugs, we have to monitor the patient every time, so that because the elimination of the drug is not getting increased with the concentration of the drug, because a constant amount of the drug is getting eliminated. There are special category of the drug also which are called, there are some drugs which follow first order kinetics at earlier stages. But when the concentration of the drug is getting increased every time, the elimination is not getting increased. Means it changes its kinetics to first order kinetics to the zero order kinetics. What does it mean? First, we are going to give a drug into 100 mg. A constant fraction of the drug was getting eliminated. 10% of that was getting eliminated. It means 10 milligram of the drug was getting eliminated. So it was following the first order kinetics. Then we have given increase the concentration. Suppose we have given 110, then also 10% of the drug was getting eliminated. After that, when we have increased the concentration of the drug, then there was no constant fraction of the drug was getting eliminated. Only 10 milligram of the drug was getting eliminated. It means it has changed its kinetics from first order to the zero order kinetics. So what does it mean? It is getting accumulated in the body. For these kind of drugs, which changes its kinetics with the increased concentration of the drug, we have to monitor the drug, which is called therapeutic drug monitoring is required for these cases. The drugs which are going to follow the which changes its kinetics, therapeutic drug monitoring is required for those. Which drug follows these kinds of kinetics? And one more thing about this, which changes its kinetics, it is called Michelson-Menten reaction. This is called Michelson-Menten reaction. What does it means, Michelson-Menten? The drugs which changes its kinetic to the first order to the zero order kinetics. It is called Michelson-Menten reaction. Michelson-Menten kinetics. First order to zero order. Therapeutic drug monitoring is required for these cases. It is called Michelson-Menten reaction. And which are the drugs which follow these kinds of the reaction? First is theophylline, phenytoin. These are the drugs which follow this kind of elimination. What is phenytoin? It is an anti-epileptic drug. What is theophylline? It is used in cases of the asthma, bronchial asthma. It is going to have effect. So these drugs changes its kinetic with the change in the concentration of the drug. So our question was, drugs showing zero order kinetics of elimination are more common than first order? No. Most of the drugs follow first order kinetics. There are few drugs which follow zero order kinetics, and there are also few drugs which changes its kinetics with the increased concentration. So option A is wrong. Second, decrease in the concentration exponentially with the time. Zero order kinetics decrease in concentration exponentially with the time? No, because there is a constant amount of the drug is getting eliminated. Next is have a half-life independent of the dose. Yes, because we are going to increase the dose, but the elimination is not getting increased. So half-life independent of the dose. It is not dependent on the concentration of the drug. Show a plot of drug concentration versus time that in year for drugs showing zero order kinetics, the rate of elimination remains constant irrespective of drug concentration. Here, a constant amount of the drug is eliminated in the unit time. For the zero order kinetics, yes, if you are going to plot a graph, then the constant amount of the drug is getting eliminated, but the rate of elimination does not remain constant. Rate, it does not remain constant. So it is half-life, the option C is correct, that have a half-life independent of the dose. Next question. Next question is a prodrug. What is a prodrug? So prodrug is a so prodrug. What is the prodrug? Prodrug are those drugs which are inactivated outside the body, but when it enters into the body, it gets activated. It is not a prototype drug. There is a difference between the prototype drug and a prodrug. What is the difference? Prototype means it is a first drug which was invented in that class. So the prototype member of the drug, no, it was not the first drug which was invented. Second, the oldest member of a class of a drug, no, it is not the oldest member. It is an inactive drug which is there outside the body, but it gets activated after the metabolization in the body. An inactive drug that is transformed in the body to an active metabolite, right? Fourth is a drug that is stored in the body tissues and gradually released in the direction. No, it is not this. So the prodrug, the prodrug offers advantages over the active form in being more stable, having better availability and less side effects. The most common example for this is the levodopa. Levodopa is converted into dopamine after getting activated in the body. Similar example, enalprelate. Enalpril is a drug which is a anti-hypertensive drug. In outside the body, it is enalprelate, and when it enters into the body, it becomes enalpril, which is active form. The prodrug is enalprelate, and the active form is enalpril. Same for the levodopa is the inactive form, and the dopamine is the active. So levodopa is a prodrug. Now the same question it is there. Zero order kinetics is seen with the phenytoin. Theophylline, these are the drugs which are going to show the zero order kinetics. Next question is the elimination after 4 half-lives in the first order kinetics. In the first order kinetics, after first half-life, the drug remains 50% after first, because it is the definition of the plasma half-life at which the concentration of the drug becomes half of the previous one. So after
In half-life, it is going to be
hello, is it audible? Okay. So we were talking about the first pass effect. Before entering into the systemic circulation, there are some drugs which enter into the liver and get metabolized, which is called first pass effect. Now there are some drugs which shows the first pass effect, like propranolol. Propranolol is a beta blocker which shows high first pass metabolism. Second drug which shows the first pass metabolism is verapamil. Verapamil is the calcium channel blocker which helps in the hypertension. Anti-rhythmic effect are also seen with this verapamil. So it also shows first pass metabolism. Other drug which shows the first pass metabolism, high first pass metabolism, is salbutamol. Salbutamol is the anti-asthmatic drugs. So it is a bronchodilator. For this, it also shows the first pass metabolism. So in the entire option, amiodarone, which is a anti-arrhythmic drug, phenytoin, which is an anti-epileptic drug, verapamil, which is a calcium channel blocker, and disopyramide, which is an antiplatelet drug. In all of the drugs, the main drug which shows the high first pass metabolism is verapamil. Next question is the all of the following statements regarding the bioavailability of the drug is true except first. What is bioavailability? Bioavailability means it is the fraction of the unchanged drug that reaches into the systemic circulation. It means, what does it means? If we have given a drug 100 milligram and if we want it has its effect in the liver, and but we have seen this in the liver, it comes only 80 milligram. This 20 milligram of the drug is not there. It means the bioavailability of the drug is 80 milligram only, 80%. This 20% of the drug is not available for the action. So where is this 20% of the drug? This 20% of the drug gets metabolized by the first pass metabolism. So that's why it does not enters into the systemic circulation. So it means the fraction of the drug which is available for the action is called bioavailability of the drug. So bioavailability of the drug, what is this? It is the proportion or the fraction of unchanged drug that reaches into the systemic circulation. It means it is correct statement. It is the bioavailability of the drug. Bioavailability of the drug can be calculated by comparing the area under the curve cure after oral and the intravenous administration. If we are going to have this area under the curve, if this is the area for the oral administration and this is the area for the IV administration. So bioavailability of orally administered drug can be calculated by the area under the curve for the oral and for the intravenous, because we know the for the intravenous route 100% will be the bioavailability, and for the oral route it is never going to be 100%. If we want to calculate the what is the bioavailability of the drug, it means 100% for the intravenous, and the amount of the drug which is present in the systemic circulation after taking the orally. If we are going to plot a graph for this, which is called this graph, in that graph if we are going to see the area under the curve, and because of that we can calculate this bioavailability of the drug. Third option is low oral bioavailability always and necessarily mean poor absorption. No, low oral bioavailability does not indicate that the drug is absorbed poorly. It does not indicate that. Bioavailability is related to the absorption, but it is not because of that only. It is not necessarily because of that. It can be because of the first pass metabolism. Bioavailability can be determined from plasma concentration or urinary excretion data. Yes, we can calculate if the plasma concentration of the drug is 100 and it is getting eliminated by the body. This is 100 milligram. Sorry. This is 100 milligram plasma concentration, and urinary excretion of this drug is like 50. We can calculate where is the 50%. It was available for the action. So the bioavailability, it is not necessarily and essentially dependent upon the absorption. The next question is the IV anesthesia. Anesthesia is that agent which are responsible for the loss of consciousness. So this propofol, it is a general anesthesia which is given for the anesthetic purpose, and it is given by the IV route. There are other routes also by which we can give the anesthesia. The second option is the sevoflurane. Sevoflurane is also general anesthesia, but we are giving this sevoflurane by inhalation route, not by the IV route. Flumazenil. Flumazenil is not anesthesia. It is not general anesthesia. It is benzodiazepine antagonist. So it is also one of the important question. What is benzodiazepine antagonist? Flumazenil is the benzodiazepine antagonist. Last option is naloxone. What is naloxone? Naloxone is opioid antagonist. It is also one of the important question. Naloxone, it is opioid antagonist. To reduce or to have the effect against the opioid toxicity, naloxone is used to reduce the effect of the opioids. Next question is the following drug which undergo most of its metabolism pre-systemically. The same question which we have seen earlier, that pre-systemically which undergoes the first, it means that drug which has a high first pass metabolism. Before entering into the systemic circulation, it gets metabolized pre-systemically. The drug is propranolol. Propranolol. Verapamil is also this. Salbutamol is also this. But highest, most, the question is most. So the most is propranolol. The question is most. So the most is propranolol. Okay. Next question. Next question is intramuscular route is precluded during the medication of intramuscular route. There are several routes as we know for the drug administration. It can be IV, it is intravenous, intramuscular, intradermis. There are several routes, parenteral, several parenteral routes, out of which intramuscular route in which we give the drug into the muscles. It can be deltoid muscles, it can be gluteus maximus muscles, and it is given in the 90-degree angle. The position of the needle should be 90-degree. So which drug should not be given by the intramuscular route? A hypertensive drugs, it can be given by the intramuscular route. Anti-diabetic drug, it can be given by the intramuscular route. But the anticoagulants, it is not given by the intramuscular route. Because when it is given by the intramuscular route, anticoagulants, what are the anticoagulants? Anticoagulants are those drugs which will inhibit the coagulation, which will reduce this coagulation formation, like heparin. Heparin is the most commonly used anticoagulant drug, or the low molecular weight heparin. Most of these heparin or the low molecular weight heparin, it is given by the IV route or the subcutaneous route. It is not given by the intramuscular route. And there is another example, another option is the antifibrinolytic drugs. Antifibrinolytic drugs are those drugs which will reduce the lysis of the fibrin. Fibrinolytics are those drugs which are going to lyse the fibrin. Antifibrinolytic which will reduce the lysis of the fibrin, like ECA, that is epsilon aminocaproic acid, and there is trenexa or the tranexamic acid. Tranexamic acid is the antifibrinolytic drug. Next question is, let's see the next question. So next question is, for arsenic poisoning, what is the antidote for the arsenic poisoning? For the arsenic poisoning, as well as for the gold poisoning, as well as for the mercury poisoning, for all of them, the antidote is BAL. BAL is British anti-acid. It is the antidote for gold, mercury, and arsenic. Next question. Next question is complete drug elimination occurs after how many hours? If half-life is 4 hours. For any drug, which follows the first order kinetics to get eliminated from the body, it should have the 5 half-life, because we have seen in the first half-life it is going to be 50%. In the second half-life, it is going to be 25%. In the third half-life, it is going to be 12.5%. In the fourth half-life, it should be 6.25%. The fifth half-life, it will be 3.15. It means almost 97 to 98% of the drug will be eliminated after 5 half-lives. So the question is, complete drug elimination can occurs after how many hours? It should have minimally 5 half-lives. So for the, if the T half is 4, then 4 into 5, 20 hours. The answer is 20 hours for this. Next question is loading dose. First, we have to understand what is the loading dose. Loading dose means when we are going to give some drug, we want there should be a steady state plasma concentration of the drug to achieve the action. To achieve that steady state plasma concentration, which is called CPSS, steady state plasma concentration, uh, we give a larger amount of the drug, which is called loading dose. There are few doses which are given in a higher amount so that a steady state plasma concentration is achieved. So this steady state plasma concentration by the loading dose depends upon the volume of distribution. Suppose if we have given a drug, then this drug, after entering into the body, as we have seen the pharmacokinetic, after absorption, there will be, first there is absorption, there is distribution, there is metabolism and excretion. So after the absorption of the drug, there will be the distribution of the drug. The drug will get distributed into the different areas of the body. So in the different areas of the body, so the loading dose depends upon the volume of distribution. When this loading dose has achieved the plasma concentration, the steady state plasma concentration, then we are going to decrease the dose of the drug, which is called maintenance dose. To maintain the steady state plasma concentration, we do not require the higher amount of the drug. We just want to maintain that steady state plasma concentration, which is called the maintenance dose. This maintenance dose depend upon the clearance of the drug. So there is two things. If we want to see the loading dose depends upon the volume of distribution, and the clearance dose, the maintenance dose depends upon the clearance of the drug. To maintain that steady state plasma concentration, which is achieved by the loading dose. Next question is the drug administration of NSAIDs in the children. The most important of the dose administration is not for the NSAIDs. For any of the drug, we cannot give the same amount of the drug as we were giving in the adults. We have to modify the dose of the drug for the children, for the elderly people, for the females. We have to modify the dose of the drug. And how we can modify the dose of the drug? According to the weight, according to the body surface area, we can modify. Like there is a formula that it is 70 into body weight by 70 into adult dose. Similarly, for the body surface area 1.73 into adult dose, by which we can calculate. So what is this? The for any children, for any elderly people, for females, we have to modify the dose of the drug according to the body surface area and according to the body weight. So the weight of the child, we have to modify the dose of the drug. Next question. The next question is we are just discussing the important questions. We are discussing the questions which are having the more weightage according to the concept point of view. So the next question is the dose of a drug required to produce a specified effect in 50% of the individuals. As we have seen earlier, for the therapeutic index, LD50 by the ED50, LD50 by ED50. ED50 is the effective dose, which is effective for the 50% of the population. So the answer is ED50, in which the LD50 is the lethal dose. TD50 is the toxic dose, the dose which is toxic for the 50% of the population. And the median dose means that dose which is effective in the 50% of the individuals. It means the quantal effect is present. It means what that median dose means. If we are giving a drug called if we are giving a drug A, which we want to see the effects that the suppose drug A is a painkiller. It is a analgesic. We want to see that if this drug A is reducing the pain to the person or not. Uh, Median dose means it is reducing in the 50%. Yes, it is reducing. No, it is not reducing. So it is the median dose which are having just quantal effect. In the 50% it is present or it is not present. That is the median dose. Next question. There is questions. Just a second, please. Drug binds to drug binds to activate the receptor in same fashion which directly or indirectly brings the effect. What is the receptor? Receptor is the receiving end. Ligand is that which binds to that receptor. The receptor is the receiving end which will receive the ligand or which will have the binding site for the ligand. And in this receptor, there are uh, some molecules which gets attached, which can have the same effect as the it was showing before. So that is which directly or indirectly brings the effects. If it is directly bringing the effect, then it is agonist, which are having the same effect like the physiological signal molecule. If a drug is having this effect, and the agonist will have the same effect. Antagonist, what is antagonist? Antagonist, it is not going to have the opposite effect of a drug. It is just going to block the action of a drug. It is just going to block the action of the drug. Just going to block the action of the drug. It is to block the action of the drug. That is antagonist. That is antagonist, which are going to just block the action of the drug. Agonist is having the same action. Antagonist is going to block the action of the agonist. And inverse agonist is going to have the opposite action than the agonist. There is always a confusion between the inverse agonist and the antagonist. Antagonists are having no action. Inverse agonist, opposite the action of the agonist. And partial agonist, it does not have the same amount of action which agonists were having, the lesser amount. Suppose agonist, if we want to understand this in a better way, we can understand by this. Okay, we can. So agonist is what? Agonist, if it is going to have effect 1, then this inverse agonist will have inverse will opposite the effect of agonist. It means it will be -1. Then antagonist is not going to have any effect. It is just blocking the effect of agonist. If the agonist was producing one effect, it is going to produce the 0 effect. Then there is partial agonist. Partial means in between two. In between agonist, it means it is less than the agonist but more than the antagonist. It means between 0 to 1 the effect will be there. Next question is, a drug A and B are compared. All are true except 1 gram of A drug causes same effect of 3 gram of B, so A is more potent. So before understanding which one is the more potent, we have to understand what is the potency or what is the efficacy of the drug. So if we are going to plot a graph, it is very important graph for a dose and response. If we have two drug A and drug B, and we are going to plot a graph between the dose and the response of a drug. It means when we are going to see if dose is 1, 2, 3, 4 and 5, the response. Suppose if this drug is for the hypertension. Hypertension, it means it is going to reduce the blood pressure. The blood pressure is 120, 130, 140, 150. It means when we have given this drug at the dose is given 3 milligrams, then this drug A is are able to have the response 120 mm Hg it is having at the 3 milligram. And there is a drug B. When we are giving this drug B to the 5 milligram, then it is producing, then this drug is having the same effect 120 milligram at dose 5. The drug A was having effect at 3 and drug B at the 5. It means we have to increase the concentration of the drug for drug B to achieve that effect which drug A was receiving at the smaller number of the drug, at smaller concentration of the drug. So it means that drug B will require more drug B require more drug. Requirement of drug for B is more than A. Requirement of the drug B is more than A. It means that drug B is less potent. What is potency of a drug? That amount of the drug required to produce an effect. So it means relatively drug A is more potent than drug B. Drug A is more potent than drug B. If we want to see the relative potency of the drug, it means if drug A and drug B both are giving the same effect means 120 mm Hg of the hypertension, both the drugs are giving the same effect. It means the efficacy of the drug is same. A and B are same efficient. but the potency drug B is more potent than drug A. By this graph, we can calculate any of the drug potency. If there is another drug, drug C, and there is drug D, the drug in this graph, the graph which is more in towards the left, it is more potent because lesser dose will be required for this. Lesser dose of the drug will be required for this. So it is always more potent when this drug is in the less towards the left. So let's move to our question. What was our question? Question was, okay, drug A and B when compared all are true except 1 milligram of A causes same effect of 3 milligram of B. So A is more potent, yes, because A is giving the same effect at the lower concentration of the drug. So A is more potent. 1 milligram of A causes effect not even caused by maximum tolerated dose of B. So drug A is more efficacious. Yes, A is giving the effect not even caused by the maximum tolerated dose of the B. So A is giving the result higher than the B. So it is more efficacious. 3. 1 milligram of A cause effect not caused by 1 milligram of B. So A is more efficacious if the 1 milligram of A is giving the results when the B is not able to give at that same concentration. So A will be the more efficacious. Efficacy is not dose dependent. No, the efficacy is dose dependent. When we are going to increase the dose of a drug, suppose there is a drug which is giving the effect at which are giving this effect at the lower amount, then it is more for this, more efficacy, more efficient. Not able to clean it, so we'll just move forward like this only. We'll just move towards the next question. Question is, next question is, to minimize the effect of diffusion hypoxia during nitrous oxide oxygen analgesia, the patient should be oxygenated for. In this, we have to understand one concept. What is diffusion hypoxia? Diffusion hypoxia means when the nitrous oxide, because nitrous oxide is a inhalation agent which is given for the general anesthesia, it is usually given in a higher concentration. About 70% of the concentration of the nitrous oxide is given by the inhalation route, and plus 30% where we give this oxygen with this, because this nitrous oxide has low blood solubility. When the by the inhalation route, when the nitrous oxide enters, then from because of the less blood solubility, it will directly try to enter into the alveoli. Because it is low blood soluble, it will try to enter into the alveoli at the faster rate. When we are going to switch off the nitrous oxide and we want to recover from the anesthesia, because of this because of the low blood solubility nature, this nitrous oxide are going to have the effect on the alveoli. It is going to displace the oxygen from that area. So because of that, there is a situation arise which called diffusion hypoxia. To reduce that situation of the diffusion hypoxia, what we do, before switching off the nitrous oxide, we continuously supply 100% of the oxygen to the person for 3 to 5 minutes. Why we supply? So that this diffusion of hypoxia, because of the lesser oxygen present in that area, which arises because of the higher concentration of the nitrous oxide, don't come. So that's why we give 100% of the oxygen for 3 to 5 minutes, so that diffusion hypoxia does not occur. One more thing about this nitrous oxide, because nitrous oxide is the inhalation agent which we give in a higher concentration. So what we can do, what is the main advantage of this nitrous oxide? We can use as a secondary gas effect, because nitrous oxide is given in a higher concentration. Along with that, if we are going to give any anesthetic agent which is less in concentration, suppose halothane. Halothane is given in a zero point 0.5 milli concentration, in the 0.5 ml concentration if we are going to give with this. So the rate of diffusion of the halothane will be similar to the nitrous oxide, because nitrous oxide in a higher amount. So along with that, the second gas, halothane, it is also going to be delivered in the same rate as the nitrous oxide. So it is the effect of the nitrous oxide, that because of the presence of the nitrous oxide, higher amount of the drug, the lesser concentration of the drug can be delivered in a higher rate. So it is called the second gas effect. So the nitrous oxide in the inhalation agent in the anesthesia has two effects: diffusion hypoxia and second gas effect. So our question was to minimize the effect of diffusion hypoxia. What we can do, we have to deliver 3 to 5 minutes, for 3 to 5 minutes 100% of the oxygen, so that does not occur. Last question for this general pharmacology: drug highly bound to the albumin. We know for the pharmacokinetics, a drug when enters into the body, it will get absorbed into the different areas. After the absorption, there is the second part, which is the distribution of the drug, and for that there is the protein binding. For the protein binding, the drug bind to the plasma proteins. The acidic drug, it binds to the albumin, and the basic drug, it binds to the globulin. Acidic drugs like NSAIDs. NSAID is the acidic drug, like if we remember, and the aspirin is a NSAID. So NSAID is a non-steroidal anti-inflammatory drug. Aspirin is a NSAID, and acetyl salicylic acid is its name. It has acid, so it is going to bind with the albumin. The basic drugs like lidocaine is the local anesthesia, which is basic in nature. Beta blocker is basic in nature. Verapamil, it is CCB, calcium channel blocker, which is basic in nature. It is going to bind with the globulin, not with the albumin. Only acidic drug will bind to the albumin. Basic drug will bind to the globulin. This was all about questions, MCQs, important MCQ, which was related to the general pharmacology. Now the questions for the ANS, blood and endocrine drugs. So we are going to see some of the concepts of the ANS in this. Okay. First question for this is, first question, So first question for this is selective beta 1 receptor agonist. What is selective beta 1 receptor agonist? First is selective beta 1 receptor agonist. Again, I'm going to open this. Just a second, please. Okay. So we are going to start with the ANS, blood and endocrine drugs. First question is selective beta 1 receptor agonist. First of all, we have to understand what is beta 1. So we know that our body has divided, our nervous system is divided into two parts: central nervous system, peripheral nervous system. Peripheral nervous system is divided into somatic nervous system and autonomic nervous system. Now this autonomic nervous system has two parts: sympathetic nervous system and parasympathetic nervous system. Now this parasympathetic nervous system acts through certain receptors which are called cholinereceptors, and sympathetic nervous system act through certain receptors which are called adrenoreceptor. So in this adrenoreceptor, there are alpha and the beta receptors. So we are talking about this beta receptor. So this beta receptors, it is of two type: beta 1, beta 2 and beta 3. We are talking about this beta 1, selective beta 1 agonist. Beta 1 specifically acts on the heart in the juxtaglomerular cells. So beta 1 receptor agonist is the dobutamine. Dobutamine, it is the beta 1 agonist. Second question is succinylcholine is a what is succinylcholine? Succinylcholine is a skeletal muscle relaxants which are used to give to relax the skeletal muscles. Usually it is given during the surgeries, general anesthesia surgery. When we want to relax the muscles of the skeletal we want for the endotracheal intubation, which we are going to perform in the general anesthesia. We want our muscles to be relaxed. Muscles of the trachea, we want that all the muscles in that area should be relaxed so that the endotracheal intubation can be done very easily. So we give the skeletal muscle relaxants. Now the skeletal muscle relaxants can be of two types, can be centrally acting and peripherally acting. This succinylcholine, it is a peripherally acting skeletal muscle relaxant, which is of non-depolarizing category of the muscle relaxant. Next question is which of the following receptor is activated by acetylcholine and blocked by atropine? So first we have to analyze the question very carefully what they are trying to ask, because in the question only we will get the answer. following receptor which gets activated by acetylcholine and blocked by the atropine? Three things is there. Receptor which is activated by acetylcholine and blocked by the atropine. There are two types of receptors which are there for the acetylcholine. Can be the nicotinic receptor and can be the muscarinic receptor. These two receptors are going to activate the acetylcholine. But for the antagonization, for the blockage, only one like this atropine, it is going to have the effect only and only on the muscarinic receptor. So because this atropine is a muscarinic receptor antagonist, the muscarinic receptors are blocked by the atropine. So the answer is 2, muscarinic. The metabolic effects of sympathomimetics are mediated by the metabolic effects of sympathomimetic. As the name is saying, sympathomimetic means which are going to mimic the action of the sympathetic nervous system. Sympathetic nervous system, the main neurotransmitter for the sympathetic nervous system is the adrenaline and noradrenaline. So adrenaline and noradrenalines are activated by the adrenoreceptors. Adrenoreceptors are alpha and the beta. So all the beta receptors are going to have the metabolic effects. Next question is the peripherally acting skeletal muscle relaxant. As we have seen, this muscle relaxants are of two types. So muscle relaxant, this muscle relaxant जो है, it is of two types. Can be centrally acting and peripherally acting. Centrally acting, there is like benzodiazepines, there is mefenicin, then there is chlorzoxazines, there is cortisoprodol. That is a centrally acting. Now the peripherally acting depolarizing and non-depolarizing. The succinylcholine is non-depolarizing skeletal muscle relaxant, which is most commonly used in the surgeries. Beta 2 agonist. Previous question was beta 1 agonist. Beta 1 was specifically present in the heart and juxtaglomerular cells. Beta 2 is present on various sites, like beta 2 are present on the bronchial muscles, bronchial smooth muscles, in the uterus, in the eye, in the blood vessels. Beta 2 are present, and beta 3 are present on the adipose tissues only. So beta 2 agonist. Beta 2 agonist. So beta 2 agonist, what it will do, all the actions which are stimulated by the beta receptors, it is going to be doing that. What we have to remember, the alpha receptor, the action of the alpha receptor is the constriction, and the action of the beta receptor is dilation. So beta receptor, it is going to have the dilation. Dilation on where? On the, because beta 2 is present on the smooth muscles, on the bronchial smooth muscles. So it is going to dilate bronchial smooth muscles. There will be the bronchial smooth muscle relaxation. That is why beta 2 agonist, salbutamol, are used in the conditions like asthma and the COPD. Because in the COPD there is a bronchospasm, in the asthma there is a bronchospasm. We want to relax or dilate the blood vessels in that area, especially in the smooth muscles, bronchial smooth muscles. So bronchodilation is doing by the beta 2 agonist. Next, the drug which is contraindicated in the hemophilia. Hemophilia is a bleeding disorder. Bleeding disorder, it means there is the excessive bleeding. So we will not give those drugs which will induce the bleeding. The drug which is contraindicated, because aspirin is a drug which is an anti-platelet drug which will prevent the aggregation of the platelets. Because of the prevention of the platelet aggregation, there will be the increase in the bleeding, and hemophilia is also causing the increased bleeding. So we will not give the aspirin because there will be the chances of higher bleeding in that person. So next question, The drug of choice for the management of the life-threatening allergic, wherever the life-threatening allergic conditions, wherever there is anaphylactic shock, we will give the adrenaline only. This adrenaline is also given very carefully, that we will give this adrenaline by the intramuscular route. And if we want to give this adrenaline by the IV route, 0.5 mg IMDP. If we want to give by the IV route, for the IV, we have to dilute this aspirin to 1:10,000 or 1:1 lakh. We have to dilute it. So adrenaline is the drug of choice for this. The next question is the drug which is used to treat the laryngospasm, bronchospasm. We will give the dilators. We will give the muscle relaxants like succinylcholine. Atropine is the anticholinergic, which will cause this bronchoconstrictions. Diazepam is the benzodiazepine. This neostigmine is a cholinergic drug, which will cause the bronchoconstriction, which will cause this constriction of the smooth muscles. So we will give this succinylcholine, which are going to have skeletal muscle relaxant action. Next question is the pilocarpine. Pilocarpine, what is pilocarpine? Pilocarpine is the cholinergic drugs. So cholinergic drugs, what is the action of the cholinergic drugs? Cholinergic drugs are going to increase the secretions of the body. Cholinergic drugs are going to decrease the intraocular pressure. In the glaucoma, there is increase in intraocular pressure. To treat that situation, glaucoma के लिए we give this pilocarpine. Previously, pilocarpine was the most commonly used drug in that situation, but nowadays we will prefer prostaglandin analog like the misoprostol for the decreasing the intraocular pressure more. So pilocarpine lowers the intraocular pressure in the glaucoma. Next is the scopolamine. Scopolamine, what is scopolamine? Scopolamine is an anticholinergic drug. Other name of scopolamine is hyoscine. It is the most common drug which is used for the motion sickness. Because it is an anticholinergic drug, it is going to reduce the secretions of the body. It is going to reduce the lacrimal salivation. Every secretion is going to be decreased by the scopolamine or the hyoscine. The most common use of the scopolamine in the motion sickness, especially the scopolamine or the hyoscine patches are available, which are taken for a longer journey. When the journey is 72 hours or more than that, then we will use the scopolamine patches or the hyoscine patches below the mastoid region. There can be on the chest, we can use this, and there will be the slow and continuous release of the drug, and the skin is going to absorb the drug. So there will be the longer effect of that drug for the motion sickness. For the long journeys, we can prefer the scopolamine as a patch for the motion sickness, not for the morning sickness, just for the motion sickness. Last question, which we are going to take in this session. In which of the following categories are ephedrine, tyramine, and amphetamine are classified? They all are adrenergic drugs. They all are adrenergic drugs or the sympathomimetic drugs. These are same. Sympathomimetic drugs, they both are same. So there are two type of sympathomimetic. One is the direct sympathomimetic, second is indirect sympathomimetic. Direct sympathomimetic like dopamine, like isoprenaline, like noradrenaline. And indirect means like ephedrine, tyramine, amphetamine, which are CNS stimulant. Amphetamine is specifically CNS stimulant drug. So it is the indirect acting sympathomimetic drug. So I think we should take this question also, which is a very simple and the basic question, yet very important. What is the antidote of the heparin? Heparin, what is heparin? It is an anticoagulant drug which will prevent the coagulation of the blood by there is a by there is activation of antithrombin 3 in the body. This antithrombin 3 is going to block certain clotting factors in the body and modify the action of clotting factors. So the clotting will not be there, and so this heparin is used as an anticoagulant. If this anticoagulant is given in an excess, so there will be the excess of the bleeding. To control that bleeding, heparin antagonist are given. This heparin antagonist is protamine sulfate. This protamine sulfate is obtained by the sperm of fish, and usually there is no requirement of the heparin antidote, because heparin itself after some time it will reduces its action. But when it is in the emergency cases, we can give this heparin antidote, protamine. When 100 international unit of heparin is given, then 1 milligram of the protamine is sufficient. When 100 international unit, why I am giving this international unit? Because this heparin is the drug which is not given orally. It is always given parenterally. Heparin as well as low molecular weight heparin is a parenterally given anticoagulant drug. To antagonize its effect, we will give this protamine sulfate, which is obtained by the sperm of a fish. 1 milligram of the protamine is sufficient for the 100 international unit of heparin. So these were the questions related to the general pharma, ANS, and blood and endocrine. I have tried to cover all the important concepts which are related to these chapters. Uh, so, thank you so much for listening.